It was.
I shot 103 the other day. Terrible.
Go ahead and just interesting. I couldn't find street parking today. Did anybody else have to park under the building? I did. But yeah, I'm going to try and see if I can somehow come up with enough money that we can just have free parking at least going forward, so it's not a disincentive. Maybe not the rest of this year, but for the following academic year, because I'm concerned somewhat our population of attendees is either very young or very old.
Why are you looking it up?
Our age is numbered here. Usually it's very good education. We've got smart young people like Jen here educating us. So this is a very, I hope, very practical topic. I often wonder myself when I'm evaluating people, why I skin test anybody to mold? Because my bias is that most people who live in the Northwest, grew up in the Northwest, are not allergic to mold, and that the efficacy of immunotherapy for mold is very marginal. So why do I bother? Other than maybe bronchopulmonary aspergillosis. So I hope I learned something new about this topic that perhaps changes my opinion on it.
So, for anyone who doesn't know me, my name is Jen Regan. So today I'll be talking about the role of mold in allergic disease.
Let's speak louder.
Okay. So today I'll be talking about the role of mold in allergic disease, about mold testing, and most of the focus will be on the efficacy and safety of mold immunotherapy. I have nothing to disclose. So an outline of the talk, I'm just going to briefly go through the different types of mold that are present in the Pacific Northwest and the role that they play in allergic disease. Also, I'll go through briefly how we test for mold. And then the majority of the talk will be kind of going through some of the papers that we basically base our practice on that focus on the safety and efficacy of mold immunotherapy. So first, what are the types of mold and what role do they play in allergic disease? And I'll preface all of this by, I really had not really looked into all of this in detail into really putting this talk together. So I was kind of surprised by just the amount of different kinds of molds that are out there and by really how little is really understood. And I think it's really challenging to study mold in human disease because there are just so many different types of mold. So it kind of depends, which ones you're studying. So what do we know about molds in allergic disease? So Cladosporium and Alternaria are the most common outdoor airborne molds that a lot of the work has been done on. And then Penicillium and Aspergillus are the most common indoor airborne molds that a lot of the work has also been done on. And I included this slide more for the fellows just because this kind of stuff has a tendency to show up on board exams. So I think looking at these kinds of pictures when you guys are ready to start studying for that is helpful because it was definitely something that came up on my board exam. So you can see right here, this is what, I don't know if you guys can see the pointer, but there's basically Cladosporium.
Is there a pointer there?
I don't know what happened to our mouse.
It's okay.
My mouse disappeared.
It's okay. So basically I just wrote in the molds that I'm going to be focusing on in my talk, but I would really look at all of these molds in terms of knowing what they look like. So you can see in the upper left is Cladosporium, then there's Alternaria, Aspergillus, and Penicillium. And so what role do we know, or what does the research show about the role of mold in allergic disease? So in a lot of the reviews and papers that I was reading, a lot of them were quoting this role of mold, specifically with Alternaria and the concern with asthma. So in a lot of the papers, they quote this 200-fold increase in the risk of respiratory arrest. When I actually went back and looked at the paper, I mean, they basically picked out 11 kids who had respiratory arrest, and then, figured out if they were positive or negative. So it was a very small group of kids that they were looking at. But, this paper, I think, really was the basis of a lot of connection between the role of Alternaria and the risk of uncontrolled asthma, specifically with respiratory arrest. And then, as we all know, there's been papers that have been shown a role of molds in allergic rhinitis, also in sinus disease, also in ABPA, as well as HP, have all been shown that mold has been shown to play an important role in. So, and then there have been studies where they basically, to prove that mold is actually responsible, they've done both bronchial testing and nasal challenge tests where they take extracts of mold, and really most of this work has been focused on Alternaria. And they've shown in patients that if they expose patients to these mold spores, that they can induce rhinitis symptoms, asthma symptoms, and also bring about eosinophil infiltration. So that has been suggested that mold is also playing a role in that way. So, so the first thing I wanted to kind of do some research on is, what molds are found in the Pacific Northwest. Because I did my training in the Midwest, where I knew that there was mold present, but everybody's been telling me since I moved here that, there really isn't mold out here. So the first thing that I did, or the first paper that I found, so there was a doctor back in 1938 who published in Jackie, basically.
Menotti knows him.
I think they trained him.
Menotti trained him.
So it's really interesting. I mean, he basically just took a whole bunch of plates and put them all around, like Seattle and the Pacific Northwest, and saw what he could grow. And these are basically the list of the things that he was able to grow. And then what he reported was this rhizopus, the one that he collected the most of. But so he did this over a year period, and then he basically wrote down his data. So as you can see, he was able to collect a number of different molds, and as you would expect, during the rainy season, he got more mold. Oops. And so he did pick up some Alternaria, some Penicillium, and then this rhizopus was basically the one that he saw the most of, which you can see with all the arrows, which basically just means it was too much to measure. So that's basically what he showed, that he was able, by just putting a bunch of plates around the Pacific Northwest, to grow mold in these plates. And then he not only did that, but then he actually grew the molds himself in media kind of stuff. And then he found patients who he tested with skin testing and then showed that they were sensitive to mold, and then he treated them with immunotherapy. So he basically made his own immunotherapy, which I thought was interesting. He didn't really, there's not a lot of details, but yeah, and then you can see here, he ultimately treated 86 patients, and again, he doesn't clarify the symptoms that he specifically asked them, but 66 out of those 86 reported improvement, so 76%. So, I mean, this was back in 1938. There aren't a whole bunch of details, but I just thought it was an interesting paper, that he was able to detect all this mold. This was back in 1938, so I just thought it was interesting.
How did you find that old paper?
It didn't, just doing a Google search, it actually came up when I was looking for this. So, this is a more up-to-date paper. So this paper was published in PNAS in 2015. So this paper was done by a group where basically they were trying to look at the whole continental U.S. and trying to look at where certain bacteria are and where different molds are. And what they did, because apparently there haven't been a lot of studies like this, so what they did is they recruited about 1,200 different families to participate all over the continental U.S., and they basically had them pick a door, an external door, and they just had to swab the top surface of the door and just send it to this lab in Colorado over the course of the year from 2012 to 2013. And then they just basically ran PCR on the sample. So they didn't actually grow the mold, they just ran PCR to see what they could see. And then they basically looked at the different molds and the different bacteria they could pick up. And what I thought was really interesting was that they reported that 74% of the different mold or fungi that they identified weren't in the databases that are currently present. So that means, it's just stuff that has not been studied. So I thought that was really interesting because, I feel like I was taught, or, when I see patients in clinic, I see a lot of patients who will come in saying that mold is causing all these symptoms, and a lot of times I'm just like, well, there's not a lot of data out there. But after reading this paper and just thinking about all the stuff that's out there that we really don't know if it's affecting patients, I just thought it was interesting. So this is basically a summary of the different mold that they saw all over the continental U.S. And this is just all kinds of molds. So you can see that most of the mold is in the southeast U.S., and they show here that it basically correlates with annual precipitation. And then if you look up where we are, they are detecting, some molds up here. So it's not like there's not any mold, but the majority that they're seeing is in the southeast U.S. And then they looked at Claudosporium, which is one of the two molds that most of the research is really focused on. And again, Claudosporium is really mostly focused on the eastern side of the U.S., but as you can see up where we are, they can detect Claudosporium, so it is definitely something that is around. But for Alternaria, which is really what the immunotherapy studies that really have the best data, you can see that's not here. So they were not picking up Alternaria up in the Pacific Northwest, and Alternaria really is more of a Midwest, Texas kind of distribution in the continental U.S. So next, so how do we test for mold? So most of us in clinic use pinprick testing, intradermal testing. Some people do it. What I was taught in fellowship is that we worry about an irritant reaction, so we didn't do it in fellowship, and I think most people really don't do it, but there are some practices that do it. Immunocaps is also another way that we can check for the presence of IgE to mold. And then obviously if you're thinking if a patient possibly has ABPA, a fungal sinusitis, or HP, you're going to order imaging to really clarify that diagnosis. So trying to look into how good is mold testing. So this paper was actually quoted in the practice parameters, and this paper is suggesting that the sensitivity of mold testing is actually quite low. So what they did in this paper is they took 44 adults who have a history of allergic rhinitis. Then they basically underwent skin testing to Alternaria, and then they also had a nasal provocation test to Alternaria. So trying to show that the patients who were skin test positive actually had clinical symptoms with Alternaria. And they did this both with the pinprick testing, which I'm showing here, and they also did it with pinprick and intradermal testing, which I'm not showing. But overall, the sensitivity was only 42%, which is quite low, and the specificity was only 44%. So this argues that the skin testing actually is not that great in identifying, patients who actually have clinically significant symptoms. And again, I think some of the challenges both for mold testing as well as immunotherapy is that there's estimated to be hundreds of thousands of molds. So how do you pick what you're going to study? How do you pick what is clinically relevant for the patient and what you're ultimately going to treat with? And this has been further complicated by it's really hard to grow a lot of these molds. When you make extracts for the molds, there's variable quality. A lot of them are also cross-reactive, so you don't know, exactly what you're working with. And then there's just really a lack of standardized extracts for many molds. The ones like Alternaria, Claudisporium, we do have standardized extracts, which I think has been why those have been the ones that there has been a little bit of research in support of. And then also finally, there is a high content of proteolytic enzymes, so that also further complicates how you're going to use these in immunotherapy. So this is just a chart just going through the different specific molds and what you need to consider if you are doing immunotherapy. So you can see that Alternaria, you have to worry about degradation of a lot of the different pollens, as well as cat, and Claudisporium also you need to worry about mixing that in immunotherapy with cat, because that is known to degrade that as well. So next what I did was I tried to go through all the different papers that have been studied or that have been published over the years to see what is really out there in terms of data for efficacy and safety of mold immunotherapy. So this is kind of a chart that I put together of the most of the studies that are out there and most of the ones that are quoted in the literature. And what you can see, the take home is really most of the studies are on Alternaria or Claudisporium. All of these studies are quite small. So if you just look at the number of patients in all of these studies, most of these are not big studies. Some of these don't even have controls, so those ones I did not focus on because it's hard to really make a lot of conclusions in observational studies. But the main take home is not a lot out there, small studies, really focused on 2 molds. And a lot of the studies really are pushing the limit of, they do give the patients a lot in the immunotherapy. And, outside of really the final study on Alternaria by Kuna, most of the studies are short term. So first I'm just going to go through the 2 studies that are most of the time published for Claudisporium. So the first study is a double-blind, multi-center study. They basically took 30 children. The mean age was about 11, and they did immunotherapy for about 10 months. To be included in the study, you had to have a history of worsening asthma during the Claudisporium season, which in this paper was done abroad. That happened to be from June to October. And then they diagnosed allergy by skin prick test as well as and/or immunocaps. So here's the protocol that they followed for the immunotherapy schedule, basically similar to traditional immunotherapy where they're doing a build-up phase where they're coming in about like once a week, and at the end, once they get to maintenance, it's a monthly schedule. But you can see that they start low, but they do go up to a pretty high concentration, or they try to go up to a high concentration of mold. This is one of the things from the paper. So it seemed like they had a hard time really showing the benefit. So then what they kind of did was they focused on the 2 weeks that had the highest score count to basically pull out a difference. And when they did that, still the majority of the time, they did not see a difference. So if you look at the bottom, which it's hard for me to read here, but they did a whole bunch of like bronchial, nasal change symptoms, peak flow, and they didn't really see a big difference down here. And what they did was compare the year 1982, where they had treated them for a year versus the year before. And really the only parameter that they saw improvement was when they did a total medication score. So that they were able to say that there was improvement, but for most of the other things at the bottom of the graph, there was really no significant improvement in the treatment in the year that they were treated versus the years that they were not. And then it's important to note that a lot of these kids had systemic reactions. So what they quoted was a rate as high as 81% of these kids had systemic reactions to this. And then local reactions was quoted at about 25%. And you can see the various doses, even at lower doses, they were having, systemic reactions. So
did they conclude that that was a positive study?
I mean, they said that. They said that there was some evidence that it could be helpful, but so. I mean, this is one of the two studies out there that are arguing.
Well, that's the best they have. They're in trouble.
Yes. So this was the second study that is most often quoted for cladosporium. So they take 62 adults, again screen for these adults who are symptomatic during that season, which in this study, again abroad, was in the late summer. And they ultimately enrolled 22 patients. The patients had to have a positive skin test as well as a positive bronchial challenge test. This also was placebo-controlled double-blind study, or this was the other was not. So in this study, one of the big limitations and what they kind of go back to at the end when they basically don't have good data is they argue that these patients are allergic to a lot of different things, which they are. So they have allergies to different pollens, they have allergies to different molds. So in their final argument is that if these patients were monosensitized, maybe the data would be better. But it is what it is. So they basically have 11 in each group, in the placebo and then in the cladosporium immunotherapy. This study is also, the other thing to consider, it's a cluster immunotherapy study. So they basically have 4 different clusters where they have these patients come in and give a whole bunch of shots, which I think also is one of the reasons maybe they have a lot of systemic reactions there too. So in the data, looking at is there a change in the symptom score, here they're showing asthma score, medication score, total score, and then peak flow change, and you can see this NS is non-significant. So no significant change in asthma score, no significant change in medication score or in total symptom score, slight improvement in peak flow, but really nothing that's nothing that's dramatic. And then the overall symptom score showed improvement. But again, there was no significant change when they specifically look at some of the breakdown scores, like the symptom score, medication score. So they basically have to, in most of their readouts, they're not really seeing a big change. But when they put everything together, then they say that they see 45% improvement in the cladosporium immunotherapy group versus a 9% improvement in the placebo group. So this paper is often quoted because everybody had a systemic reaction. So yes, they're doing cluster immunotherapy, but everybody had some sort of systemic reaction and who got the cladosporium immunotherapy, and 70% had large locals. And it's not even just one reaction per patient. If you look at the graph on the graph B, so the y-axis is the number of reactions per patient, and the x-axis is the pre-treatment asthma severity. So each of those little triangles is a patient, and a lot of them are having like 5 systemic reactions over the course of the study. So, and nobody has no systemic reaction. So this really argues about the safety of this kind of immunotherapy. So this is just going through, well, what were the systemic reactions that they're quoting? A lot of them were asthma reactions, angioedema, hives, hypotension, those kind of things. But that's the main take home from this study is that yes, they did cluster immunotherapy, but it really was not a safe treatment. So this is, again, just showing the incidence of systemic reaction, and it did increase with the total dose that was given during the cluster treatment. But you can see, yes, once they kind of go above like 40 and above, there's more delayed local reactions, but the systemic reactions really, once they hit 30, a treatment dose of 35 and above, they're getting lots of systemic reactions. So to summarize the cladosporium studies, the take home is they really didn't show a tremendous amount of benefit, and really the safety of a lot of this is, came up. So there's a high incidence of systemic reactions with these studies. Yes, some of the limitations are, maybe we shouldn't be doing cluster immunotherapy, maybe they shouldn't have been pushing the doses as high as they did, but there isn't really data out there doing the opposite, so we don't really know, we don't really have that to support it. And yes, in the latter study, the study participants often did have multiple other environmental allergies, which complicated it, so that is another limitation. So most of the immunotherapy studies have focused on Alternaria, and I picked the two most recent and the two, I would say, strongest papers out there that I'll quickly go through. So the first one is a double-blind, placebo-controlled study, and they basically took 28 patients who had clinical symptoms, and they had to have a positive skin prick test with a commercial-grade Alternaria and or a specific IgE. They had to, in this study, they had to be monosensitized, so that was an improvement in the controls for this study. And this is basically the demographics. Again, it's still a somewhat small study. There's only about 14 in both the active group and the placebo group. And this also was a younger age. The mean age was about like 12 to 15. And they followed a more traditional immunotherapy schedule. So buildup was weekly. Once they got to the maintenance dose, which in this was 1670, then they're getting it monthly. And then the duration of treatment for this study was a year. So this study, the one thing I didn't like about this study, they, for some reason, even though it was a tiny study, they divided people into groups. So this T0, T1, T2, T3, they divided into 4 groups. And they don't really explain why they did that, but then they kind of control within those groups. And it just makes me question, do they have to do that to kind of get a change? Because in such a small study, it would seem to me, why don't you have 2 groups and just collect all the data and show me the 2 groups. And they do that sometimes, but then sometimes they break them up into these 4 groups. So I thought that was weird. But you can see the data is at least stronger here. So looking at peak flow, you can see that was improved in the group that got the immunotherapy versus the placebo. Looking at rhinitis scores and asthma scores, you can see that also was improved in the group that was treated. And then down at the bottom, they have this visual analog score, which basically means the patients got this survey that covers all the different symptoms possible. And again, there seems to be slight improvement in the patients that were treated versus not. Here, just again, looking at more scores that the patients filled out via surveys, and you can see overall the patients that did receive immunotherapy, there does seem to be an improvement in the scores when they're looking specifically at symptoms for rhinitis as well as asthma. Most of the time they are seeing an improvement in the treatment group. And so was there safety concerns with this study? So not so much. So here they are using standardized extract, and it is typically, in this study, it was pretty well tolerated. They, out of the 711 IT doses total that were given. Only 2 adverse reactions were reported in total. One reaction, the patient just said that they had some skin itching at the site, but there was nothing that was, they couldn't see any rash, so, and that resolved. They gave them an antihistamine and it went away. The second one occurred when on a maintenance dose, they said they had some like runny nose, itchy eye symptoms. That came about 60 to 90 minutes after the shot and resolved without any intervention. So in contrast to the cladosporium studies, there really were not the same safety issues that came up. So next, this is the final study I'm going to go through. And this is, again, looking at Alternaria. And in this study, they are looking at similar, it's again in like children, and similar studies. So they're looking at kids 5 to 18 and who had to have symptoms during, that clinically sounded like Alternaria symptoms during that season. They had to have a positive skin prick test, again using a standardized extract, and then they also had positive IgEs.
And they were monosensitized, or what did you say? I don't know how you find people monosensitized to just.
So I think they would say monosensitized to mold. They wouldn't say monosensitized just to Alternaria. I'm pretty sure this was, I can't remember. I don't want to say for sure. I think it was, but I think it was. But I'd have to go back to the 100%. Okay, so in this protocol, basically they screened a total of 4,000 patients, ultimately ended up with 20 patients who were on the placebo arm, and then 30 who got the active therapy, and then ultimately only 19 completed it on the placebo arm and 25 completed it on the active arm. This was a nice study because they did treat them for 3 years and then they followed them out for a total of 4 years. So it is by far the longest study that I could find. So for the demographics, again, just already what we talked about. Most of them are kids around like 11, 12, and then they have asthma, rhinitis, conjunctivitis, those kind of symptoms. This was done in Poland, so they wanted to focus the study on the time of year when the Alternaria count was the highest. So in Poland, that happens mostly in August. So they focused the study really in July, August, and September in terms of getting clinical scores and all of that. So here you can see the various clinical scores that they did, and they were asking the patients during the time of year when the mold count was the highest. And you can see at the baseline, there was really no significant difference between the placebo and treatment group in the upper left. But after 1 year of immunotherapy, the patients who got immunotherapy started reporting improvement, and you can see that just gets more dramatic as they look year 2 in the lower left, and then year 3 in the lower right. So this is suggesting by the medication score that there seems to be significant improvement in the population that receives the immunotherapy. So next, this is looking again at symptom scores. So here we're looking at, in A, they're looking at asthma, B, they're looking at rhinitis symptom scores, and C, they're looking at conjunctivitis symptom scores. And in the patients who received treatment at baseline, you can see, regardless of what you're looking at, there is not a significant difference. 1 year out, they're starting to see a significant difference in the asthma scores, but really nothing significant in the rhinitis or conjunctivitis. And then 2 and 3 years out, in all 3 categories, they are seeing significant differences in the symptom score in all 3 categories, suggesting that the group that gets treated is getting clinical benefit from the immunotherapy. And then finally, the patients were treated for a total of 3 years with immunotherapy or placebo, and in this graph, they're looking at after 4 years, so 1 year after completing immunotherapy, did they still have a benefit? And that you can see in the group that got treatment that their symptom score was lower 1 year after they finished the immunotherapy versus the placebo group where there really is no significant difference. So this argues not only during the 3 years of treatment that the patients reported clinical benefit, but even 1 year out of immunotherapy, these same patients are reporting, that continued clinical benefit from receiving the immunotherapy. So were there reactions in this group? So in the treatment group, which consisted of 30 patients, the most common side effect that was reported was just basically large local at the site. And this was reported by 4 patients. And then one patient said that he or she had a headache about 1 hour after injection that resolved on its own. But that was the only kinds of reactions that were reported in all 30 patients. In the placebo group, 2 patients had some facial flushing and redness, and then one patient, every time they got an injection, or they had basically, or one of these patients reported it every time, and the other patient reported it only after 8 months. But again, they were receiving placebo, so that's really a non-issue in terms of the Alternaria immunotherapy. So, summary of the Alternaria studies. Overall, it seems like immunotherapy was overall well tolerated, especially in the final study I just presented. I think it argues that there is clinical benefit, and they followed these patients for as much as 4 years after the initiation of immunotherapy. They saw clinical benefit in asthma, rhinitis, conjunctivitis. Some of the limitations are that all of these overall are small studies, and there really hasn't been research out there for the other molds, so it's hard to really know what we should be doing in terms of offering treatment options to patients when we really don't have a lot of research based on these other molds.
I'm curious. So my takeaway from this is that last study is the only one that's probably credible. And so maybe immunotherapy for Alternaria works, and also you showed us we don't have any Alternaria here. So the idea that we should not use mold immunotherapy in the Northwest holds up pretty well. But you came from Chicago, so what's done in the Midwest? What were you taught to do back there?
So, I think at Northwestern, I don't think we did mold immunotherapy, just because because the data isn't that strong for it. But I think, there are some groups and stuff that do it, but where I was trained, we did not do it.
Did you skin test people?
We did skin test it.
So that question is, why do you test them if you're not going to do anything with the data?
Yeah. I feel like a lot of times, we were worried about ABPA and that kind of stuff, because that came up a lot in clinic with more ABPA, but yeah, I agree.
We don't need to test for Alternaria to diagnose aspergillosis. I'm just
being
devil's advocate
Right.
here.
Right.
Does anybody here put people on mold immunotherapy? I never have. Once?
This one's
Yeah.
a lady monosensitized to Alternaria, and she said she got better, but my N of 1.
Yeah, but did she live somewhere else before she moved here?
Sure, she was from Anchorage, Alaska.
Anchorage?
And she was monosensitized to Alternaria, so I said, yeah, it can't hurt to try.
We usually teach the fellows that what I say is, it's wet and damp here, but it's cold, and you don't breed significant outdoor mold spores in that situation, so lifelong Northwest residents, for the most part, shouldn't be mold allergic, and as you just showed us, the data for immunotherapy is so poor that why bother? On the other hand, I don't know, you didn't mention it, I was always taught a long time ago that in New Orleans, when it would rain, there'd be peaks of emergency room visits for asthma, and you could track that a day or two after the mold spore counts went up, as evidence that you really can provoke respiratory disease from mold in the right climate. We don't have that climate here.
So that, the thunderstorm asthma you're talking about?
Well, that's different. That was the guy who presented at the national meeting. I thought it was a terrible talk.
But that was Alternaria, was the thunderstorm.
Yeah, and that was in Melbourne. But I don't know what mold it is in New Orleans. And this is old data from a long time ago. But did you come across that?
So what I was reading with the thunderstorm asthma, so it's Alternaria, it's been linked with that, but it's also grass pollen. So it's kind of like those two, when the thunderstorm happens, they say like the particles like get smaller because of whatever, and it's easier to inhale then in those climates, and then that causes the, but yes, because it sounded like it was not only the Alternaria, it was really like the grass pollen too. But yeah, I don't know in New Orleans in terms of like the specific mold that they've seen with rainstorms and stuff.
I talked to Tom Greer about this because we had a meltdown in our refrigerator and lost a whole bunch of allergen. And he predicts that in the next 10 years we're going to be down to 7 molds, and that's all that's going to be available for us to test for. As he said, the other stuff self-digests. They can't standardize it because it keeps auto-digesting. And he predicts we'll have 7 extracts by the year 2000.
Well, we don't even test for 7 now.
No,
We
we do
test for
5.
4 or 5.
We do Alternaria, Aspergillus,
Penicillium.
Penicillium, Cladosporium, and then I don't remember our 5th one. I don't know.
And
But
then-
obviously it doesn't, and then sometimes people come in and they want all the molds, and I think there's like 14 of them, but
We have
I
14,
mean, I think
which we'll let
that's-
them have if they want.
yeah.
Well, I mean, as most all of us know, the people who come in complaining about mold, they're complaining about the aromatic compounds that make a musty odor in their basement, which have nothing to do with mold spore counts. But they have this, from the media, the internet, this idea that the stuff is toxic. And it's all
Well, the good news, they're almost always skin test negative, so you can tell them that it's not mold.
yeah, I'm not sure that they walk out the door not believing that, but
How come this is such a medical legal nightmare? This is,
Yeah, that's the thing.
It's
Damage,
not-
water damage in homes.
Yeah.
It's a toxic
Offices.
mold.
It's just a horrible thing. They come in and they've already retained an attorney. They're trying to prove that the mold is what drove them out of their house.
right.
We get nothing, and then they get mad and go to somebody else and get nothing. It's just the amount of effort that they put into this is huge.
Yeah.
But I don't know what to do with those people because they're skin test negative, like Gary said, usually, and their IG is like 12, and then, okay, what do you want to do? So I don't know why we get stuck with all this.
that's the problem with living in a democracy.
So just to summarize,
Good transition.
We may not stay a democracy the way things are going, though.
okay, so basically, as I said, there's just really there's not a lot of data out there. The data that's been done is really focused on Alternaria. Cladosporium data is really not that good. And then with Cladosporium, I would just argue you really need to think hard if you're going to put a patient on immunotherapy for that based on these studies, because these argue that you really probably shouldn't based on the safety profile. And then in summary, I think there's really a lot we don't know, and just the amount of different types of molds, and it's hard to grow the molds. So I think, and reading through the literature, there's really, hopefully there will be more research that's done to clarify this, and to help patients who show up in clinic who are convinced they're allergic to mold, because seeing how little is out there, I think it's hard to necessarily say 100%, that there can't be a role that it's playing, but the research out there is poor at best. So that's it. Any questions?
I'm just going to diverge from this a little bit because we've made our comments already about it. The data you showed that there was 1 year continued efficacy after 3 years of immunotherapy makes me wonder what those of us in the room tell patients, not about mold immunotherapy, because we're not doing mold immunotherapy, but more conventional, say, pollen immunotherapy, where there's no question that it's efficacious. I've always let people go on immunotherapy as long as they want, even though the standard is 4 or 5 years. And I'll just tell them based empirically on experience that I think about 25% of people lose their tolerance within a year of coming off. and I don't know if there's any data to support that. That's just my observation, and I tell people your choice is to stay on. You can stay on as long as you want, 6, 8, 10 years. If you don't want to take the chance that you'll lose the tolerance within a year, then you have to start the whole process over again. Anybody else? Anybody think that's wrong or handle it differently? Or I'm wondering if more currently trained people are stricter about saying after 5 years you're done and you should come off of immunotherapy? Anyone?
I do what you do.
Yeah.
You know, I tell them,
5 years.
I don't know where I got the number. I say 2/3 continue to do well after 5 to 7 years, but 1/3 fail. And if you relapse and it's more than a year, you got to start over. And a lot of people, even if their allergies are all gone and they're now vasomotor rhinitis, they're older age, they just want to continue. And it's fairly harmless.
You're
I
the
do 5
youngest.
years. I
5 years you tell people you're done?
Yeah, well, I just tell them, well, you know, I started even at about 3 years. I start telling them that, you know, we usually do this for 5 years, and I usually stop them. And then, you know, if they come back, most people aren't coming back. Or if they are, it might just be like grass season is still really tough for them. You know, I don't know. I don't usually keep them. And I will say that there are people that are on shots for like 25 years, and, you know, to try to talk them into skin testing again to see if they even need to be on shots is really hard.
Well, that's, I think, a different group of people who came from, like, retired ENT people who put people on shots that never needed it in the first place.
Exactly.
That's a different issue. I've always felt if they're strongly allergic, we proved that in the beginning, and they want to stay beyond 5 years, the relapse rate is high enough that I tell them, you know, if you stop, you're going to have to go through that build-up phase again, which is a nuisance and time-consuming. The other unrelated question to this, just about immunotherapy in general, when you hear Steve Durham talk, or the Europeans, about the equal efficacy of sublingual and subcutaneous, I don't buy it, actually, but, you know, we've always been biased that subcutaneous is better. But I'm not sure if they're really analyzing the data. Like, if they say someone they just treat them with grass, for example, but they're really multi-sensitized, but they didn't take that into effect. If they're annualizing their symptoms, or they're just comparing the symptoms over the grass season, because if we have people who are dust mite and tree and grass allergic, we'll look at their symptoms over the course of a year. So I'm not sure they're comparing apples and oranges or apples to apples when they say that sublingual is as good as subcutaneous. It's just we should ask the guys who are proponents of sublingual immunotherapy. I don't know, anybody else had any ideas on that?
Are you doing very much of that?
You know, when it first came out, and for some people, grass sublingual clearly works. There's no doubt about it. But you really have to find people who are monosensitized to grass. If they're not, I haven't done it. And actually, in the subsequent years since the product come out, I've done less of it. And I haven't put anybody on the dust mite product. And I think the data for the dust mite product is even a little weaker than it is for the grass product. So, again, anybody?
Well, what I see when I put them on SLID, they don't come back the second year, so I don't know whether they're cured or they've just given up. Because I don't think I put people on it 2 years very often. Usually they go a year, and then that's the last I see.
I don't think anybody's cured in a year.
I agree. I'm just thinking they probably don't think it works. So they
But
don't come
you
back.
know, a couple of years ago, they had the compliance rate data. You would think if you offered somebody a treatment they could do at home, and they're motivated, like 80% would stay on it. But the actual rate is in the 20s. So people just give up on it, even though you're allowing them to self-treat at home. That says something about human nature. But
That fits the medication utilization.
it's expensive.
It's expensive. People get drugs that they don't take. Not a big surprise the sublingual doesn't get used.
All right, thank you. So you actually haven't changed my mind. We don't have mold and we don't give people immunotherapy.
It reinforces your
My
impression,
mind.
so I appreciate that.
What do we have next
Came
week?
in by us.
Anybody know what we have?
I don't have a still.
Gary's presenting in 2 weeks.
Oh, what's